Hello, everyone. This is Kayla Maxwell. I'm voiceovering my case study for Nurse 680 Clinical Practicum at Spring Arbor University. This is on a patient that I encountered in my primary care clinical. I was at a family practice in central Pennsylvania. The patient for this case study is a 54-year-old female. I titled the case study Medication Adherence. We'll dive more into the exact details of the case study. However, I did choose this patient because I found the scenario interesting, and I also believe that medication adherence is something that we'll encounter probably more frequently than we would like to as future practitioners. So definitely something to get exposed to while we're students and think about how we may handle that in the future. So going ahead with the case study. The chief complaint, the patient said, "I'm here for my scheduled 6-month follow-up, but I was just in the hospital emergency room the other week." HPI, the patient LB, is a 54-year-old female that presents for follow-up on chronic disease management. She reports that she was in the hospital room just 13 days prior, so unfortunately, the chronic disease management appointment now just became like an acute post-hospital discharge appointment as well. The discharge summary was able to be reviewed because at this location we have electronic charting where there was a Care Everywhere setting within Epic, and we could access the records from the hospital. So blood glucose on arrival to the ER was 476. With discussion with the patient, she admitted that she was mismanaging medication and believes that she was accidentally taking potassium supplementation rather than metformin for the duration of approximately 4 weeks. Her potassium level was normal, though. It was 4.6 in the ER. Based on the report written by the ER that we access, the patient was administered some IV insulin. Her blood glucose subsequently decreased to 135, and they discharged her home from the ER with no hospital admission. Since discharge from the ER, the patient reports that all medications have been being taken appropriately, and she's been feeling much better. When questioned about her last fasting blood glucose, she does report that 4 days ago it was 153, but that her blood glucose monitor hasn't been working and she hasn't taken any sugars in the last 4 days. So for some past medical and surgical history on our patient, diabetes mellitus type 2, hypothyroidism, depression, generalized anxiety disorder, idiopathic cardiomyopathy, cardiomegaly, a left bundle branch block, COPD, and surgical history of carpal tunnel release, a total hysterectomy with removal of tubes, and cardiac catheterization where they found an EF of 15%. For family history, the patient's mother deceased at age 77, hypertension and MI. The father deceased, age 64, pancreatic cancer. Her sister is living, but there's no known medical conditions. Both of her paternal grandparents are deceased with unknown medical history. Maternal grandmother is deceased with a history of hypertension and ovarian cancer, and the paternal grandfather is deceased with a history of MI. Social history for LB. She's a 54-year-old woman who is single and lives alone. She's never married and has no children. Her support systems are minimal, as she states she has little contact with family and few friends. She works in the office setting full-time. She has a history of depression and anxiety disorders. She reports that they're currently controlled with medication and therapy. She is currently a 1-pack per day smoker for the last 23 years. She seldomly drinks alcohol and does not do illicit drugs. She reports feeling financially secure. Her hobbies include reading and participating in a book club. Current medications for LB include an albuterol inhaler, which is a PRN medication, the Anora ellipta inhaler, 2 puffs by mouth, QID, lorazepam, 1 milligram tablet PRN. That is Seroquel, 400 milligrams at bedtime. Novolin insulin, 60 units injected under the skin daily. Levothyroxine, 75 mic tablet, 30 minutes before breakfast, that's daily. Metformin, 1,000 milligram tablet BID. Simvastatin, 40 milligram tablet daily. Bumex, 1 milligram tablet daily. Enalapril, 10 milligram tablet daily. Spirulactone, 25 milligram tablet daily. Aspirin, 81 milligram tablet daily, and a potassium chloride 40 milliequivalent tablet daily. While we're looking at this medication list, I do want to address back to the HPI that the patient reports that she believes that she was taking potassium supplement rather than metformin. So, unsure completely if she was doubling up and taking 2 potassiums in the morning and 1 at night, which would mean that she was having 120 mil of equivalents a day. But the point is that she was not having any metformin administered to her for a 4-week approximate time period. So she is on a rather good dose, 1,000 milligrams BID. So without that, it was pretty inevitable that her glucose was going to get out of control. But do also want to address that she was potentially taking double to triple, if not an unknown amount of potassium chloride supplementation, and her potassium was still normal. I don't think that's an immediate concern that needs to be addressed, but something to think about in the future about, her potassium management. For review of systems, here on the main screen, I just put what I wanted to address. If you want to look at my full review of systems, just go in my PowerPoint and open up the notes section. I apologize for that inconvenience if you wanted to look at it now, but just cardiovascular and respiratory were the only areas of positive complaints for the patient at the time. Another thing that I want to address with the review of systems is that they include chronic cardiovascular and respiratory complaints. All review of system complaints should be looked at and investigated as to why the patient is experiencing that. But one thing that I did learn from my preceptor in clinical, that if a patient presents and has a chronic disease and has a chronic complaint, that you always want to compare it to baseline. So when you're talking to your patient during exam and with the review of systems, comparing to baseline, how is that for you normally? How does that differ? Is it worse? Is anything getting better for you? Just to have a little bit of an idea of what you're working with and how that might apply to how you're going to address your patient needs and care plan. So back to this patient LB, cardiovascularly, no complaints of chest pain, no shortness of breath, no paroxysmal nocturnal dyspnea, but did have dyspnea on exertion, positive orthopnea, no claudication, did complain of positive edema, and no complaints of palpitations. For respiratory, does complain of positive cough, positive sputum, no wheezing, positive smoke exposure, and positive dyspnea. For physical exam, I apologize.